Thank you so much for the kind introduction and having me here. So the question for me was, does every parastomal hernia need surgery? And I think it's a really easy one to answer. So first of all, my disclosures, they're not relevant for this presentation. And the answer is really easy, no. Like the speakers already said, like it's a depressing topic. It comes back, it recurs a lot of time, and surgery is not very easy to perform. Although it's a very common problem to have, we are not exactly sure what the incidence of parastomal hernias is. But if you look into literature, the general consensus is that the most frequent parastomal hernias are seen in end colostomies. It's up to a third or half of patients after a year, and then in declining order of incidence, the loop colostomy and the loop ileostomy. And until recent publications, there was no real consensus on what even the incidence, for example, for ileocondyles was. Until this year, there was a nice systematic review that came out and that showed that ileocondyles, who are thought to have a really low incidence of parastomal hernias, even have a 26% incidence of incision of parastomal hernia on CT scan after 2 years, which is quite high. So with this frequent problem, the question is what you're going to do. Are you going to wait or are you going to fix it? So waiting is a good option, but it has some risks. So the risk of waiting are, of course, strangulation, getting into emergency surgery, but also enlargement of the hernia, making it more complex to fix, and for the patient, developing comorbidities, making it more complex patients with more perioperative risks. And quality of life can really be decreased in these patients. So why are we not fixing every hernia? Well, because the results are not that great. And if you're looking into literature, it's really hard to find good recurrence rate, good studies looking at recurrence rates. So what is actually the result of what we're doing? And this testimonial review is already 10 years old. It's from 2012 and was actually the first one to really look into literature, what was known. And as you can see, there are really small groups reported in literature. It's sometimes 20 patients only per repair technique that we know. But what you can see that we know for sure that suture repair has a 70% incidence rate. I'm not sure if I can show you. Oh, no, I can't, sorry. Has a 70% recurrence rate, which is unacceptable high, of course. But if you're looking at open or other techniques with the mesh being implanted in different planes, laparoscopically or open, there's also, non-acceptable recurrence rate in some techniques. For example, the laparoscopic keyhole technique shows a recurrence rate of 35%. But knowing that these studies are in small groups of patients and probably published by people that are good at doing this surgery, the real incidence of recurrence will be much higher. And there are other treatment options to go for. If the complaint of your patients is leakage, or you can go to your ostomy nurse, and if you have a good ostomy nurse, they can fix the majority of those complaints with new materials or topical barriers they can apply, and a lot of the complaints will go away and they don't need surgery. If it's discomfort or a cosmetic appearance, often a supportive garment will relieve a lot of those complaints. They can be made patient fit, tailored to every patient, and often a lot of patients don't need surgery after that. And if it's an inconvenient location, for example, it was placed during an emergency surgery or a patient lost a lot of weight, you can think about stoma relocation or even reversal of the ostomy and closing the defect or fixing the hernia in a later stage. So when you're thinking about taking your patient to surgery, there are some things you have to consider, like what type of ostomy is it? Is it an ileostomy? Is it a colostomy? Is it a urostomy? Are there ureters involved, which can make it very challenging to fix? Is it end or is it loop? Loop being difficult to fix. Is it permanent or temporary? Can I maybe reverse the ostomy? And think about what was the underlying disease that got the patient this ostomy. Was it cancer? Was it metastatic? Is it treated already? Is it temporary just to get the patient to chemo? Was there an infection going on? If the patients went through severe peritonitis, you're going to get into a lot of adhesions. You really want to rethink if you want to do that. But also for a patient with IBD and active Crohn's, do you want to put a mesh next to a bowel that's still infected or inflamed? And a patient that has a slow transit colon, for example, if they have functional complaints with their parastomal hernia, often they will still have functional complaints even after you fix the parastomal hernia. So it's all about managing the expectations of your patient. And also looking into the patient, do they need future treatments? Do they need chemo? Do they need additional surgery? So for me, the question is, when is timing? If you want to take your patient to surgery, what is the best timing? I often wait 6 months after major surgery for the patient to recover, for the patient to get, back on their feet, but also get some psychological acceptance of their ostomy, like learn to live with it, see how it works for them, and see if they really want surgery after being through often very major surgery already. And also, I really want my patients to have their curative or adjuvant treatments, finished. And that gives you some time to modify the risk factors to really get the best results for every patient. And if you go into surgery, you're getting the best results. They can have weight loss, bariatric surgery even. They can stop smoking, you get their pulmonary function better, you stop maybe get them off steroids, and really get the psychological acceptance there and talk with your patients about that. Like, what are you expecting from me? How can I help you? So, these considerations are, of course, theoretically. So I'd like to take you through some of the cases of patients that presented to me with a parastomal hernia and seeked repair, and the considerations I had and the complicated factors they had. So this gentleman came to me, 78-year-old male, who was almost 8 years out of his rectal cancer surgery, had a minimal invasive low anterior section with end colostomy, and only prostate cancer. So a fairly healthy gentleman, BMI of 29, and his complaints were discomfort during hiking, very active lifestyle, cosmetics, and really leakage. And if you look at this, it was a non-reducible hernia. So you can imagine all those bowel loops being under your skin. It's very uncomfortable putting a supportive garment over that. So I found these complaints, really justifying surgery, and I did a minimal invasive repair. I didn't see any adhesions. It was a fine repair. He went home 2 days later. So this was a good candidate to do it on. But they're not all this clean cut. So this lady came to me, and yeah, we have obese patients in the Netherlands too. She's 52 years old, BMI 48, and an active smoker, of course. Those are always coming together. And she presented 1.5 years ago with acute Hartmann's disease, acute perforated diverticulitis and got a Hartmann's. And she came to me with severe complaints. She had a lot of pain. It leaked all the time. It kept her in the house. She was immobile. Her quality of life was decreased. She was crying in my office to help her. But if you look at the CAT scan that I made from her, it's not only a parastomal hernia, she also has a concomitant incision hernia, and that really complicates her repair. So her defect is spanning over 16 centimeter width. With this loss of domain and her BMI and her smoking, I just can't fix her at this moment. So surgical repair, no, I can't do that. I can't fix this, I can't make her better, I can only make her worse. But she was willing to go into bariatric surgery and consider that. And when she is coming back and she lost the weight, we can definitely reconsider this. And this is real, for her, that was the reason to go into bariatric surgery. And then this lady, people that survived an abdominal catastrophe. So this lady presented to me, 70 years old, like over a year ago, with an obstruction in her sigmoid. She has a medical history of cardiovascular disease. She's on anticoagulants. And she had a horrible case. She presented with us obstructing in her sigmoid with a distended, very severely distended colon. So we took her to the OR. She was in an emergency surgery. She was malnourished. And we did an open Hartmann's and an appendectomy just to desufflate her colon. And then her appendiceal stump started to leak. So we had to take her back and we had to do ileocecal resection. So she now had a colonic fistula on the left and an end ileostomy on the right. And then, of course, the serosal tears from her severe distension started to leak too. We had to take her back, several reoperations, severe peritonitis, and she ended up with an open abdomen that granulated. So more than a year later, she presented to me with this wound that's not healing in the midline because there's so much distension on it, and complaints from both of her hernias. So the surprising thing was that she had no complaints of her midline hernia, but she was only complaining of her parastomal hernias. So for the ileostomy on the right side, she was complaining about leakage, she had severe dermatitis and cosmetic aspect. And for the left side, her colonic fistula, she actually complained only of cosmetic appearance under her shirt. And if you look at the CAT scan, the colonic fistula isn't really a hernia, it's just a bulky mesentery in her subq, so I don't think you can fix anything for that. But for her ileostomy and her leakage and her dermatitis, you want to help her out. So what we did was, we did an open local revision of her ileostomy, did an onlay mesh, and we told her we're never going into your abdominal cavity again. It's just inaccessible. And the other one, it's a shame you have cosmetic complaints, but I just can't fix that. No, I will make you very sick by fixing that. So yes, but you really have to tailor your approach. So for parastomal hernia surgery, it's not something to tread lightly on. It's surgery where you have to select your right patient. What are the expectations of the patient? What do they want from you? What do they want changed? Do they have modifiable risk factors? Are you expecting to see a lot of intra-abdominal adhesions? Is it going to be a nice minimal invasive surgery, or is it going to be like a really big surgery with the patient being in the hospital and really prone to infection and complications? Is there recurrence? Is there a mesh there? Is it in which plane is that mesh? Is that mesh infected? Is there a loss of domain? Is your patient, suitable for MIS or open? It's a discussion you really need to have with your patient. And I think it's very important that you select the right surgeon or team for this. Don't just fix 1 or 2 hernias a year and just see how it goes. You really need somebody that has some volume and has experience. I think recurrence rates will be much better with an experienced surgeon. You often need an AWR surgeon, especially with a concomitant hernia, a lot of loss of domain, how to handle that. You need a colorectal surgeon often on your team if you really have to relocate the ostomy or do some bowel resections, or with maybe team up with a urologist and stent the ureter before you go into fixing ileochondral hernia. So thank you so much for your attention.